Discussion on the emergency options for the complicated MDR infections. As we know, antimicrobial resistance is rapidly growing threat worldwide. The emergency of the multi-drug bacteria, emergence of viruses and fungi, they pose a serious challenge to our ability to treat even common infections. And this panel discussion will basically brings together the group of experts who will be talking about the latest advancement in the diagnosing and treating these intricate infections. Now I'll invite moderator Dr. Rajesh Mishra, who is honorary consultant intensivist and internist at Ahmedabad. He's attached at Epic Hospital, Kidney Hospital, Naranapura, and sir has remained as a president-elect ISCCM and the chairman of scientific committee also. As a panelist, I'll invite Dr. Manoj Singh. Sir is a senior consultant chest and the critical care at Zydus Hospital, Ahmedabad. He is affiliated as a teacher in DNB and IDCCM, affiliated to critical care ISCCM and ESICM. Sir has lot of national and the international publications. Next, I'll invite panelist as Ranveer Singh Tyagi. Sir is director of the Department of Anesthesia and Critical Care, Synergy Plus and the Galaxy Hospital, Agra. Sir has remained as a vice president of ISCCM and zonal member. I'll also invite Shrikant Srinivasan. Sir is chairman of the Manipal Institute of Critical Care Medicine, Manipal Hospital, Delhi. I'll invite Ritesh Shah on the stage. Ritesh Shah is the director of Critical Care Medicine Department of the Sterling Hospital, Vadodara. And next I'll invite Dr. Amit Darsandia. Meet Darsandia, who is an ID specialist. He is practicing as an infectious disease specialist and the HIV specialist at the Tropical Medicine Clinic, Ahmedabad. Over to you. Thank you, sir.
So, hello. So, good afternoon, and probably between lunch and this discussion I am standing, so we'll try to make it as interactive as possible. If I can get everybody's attention, I can finish it quickly. And if you talk on yourself, then it will be difficult for us to do this important discussion. So may I request everybody to take their seat, please, if possible. Okay. So first of all, thank you, Samir, and all Abhishek, Rajit, for the invite. And I have got very wonderful panelists, expert in their area. Why this discussion is important? The next pandemic, which will be probably more fatal than what COVID was, and probably this is going to affect everybody involved, is going to be pan-drug resistant bacterial infection. And this is really going to be predicted, and that's what everybody is putting efforts that probably we can prevent. I don't know, it's avoidable, inevitable, but this is the next problem which we're going to face as a pandemic. So based on that, I take a case thing, and we are going to build up the case based on the some principle which we know not know everything. And in between, if somebody has any input, you can raise your hand. We'll take your question also in discussion. Very happy to that, but one person at a time, not everybody. So I'm starting with this case. This 20-year-old polytrauma patient was brought to you. I'm saying it can be anybody. He has a history of head injury, lung contusion, right femur shaft fracture, liver contusion. And on 5th day, he's brought to you with fever, tachypneic, hypertensive, GCS has gone down a little bit, but CT scan, not operable lesion, and has got bilateral cellular edema. In previous hospital, he has received antibiotic, typically the combination of meropenem and targocid, which everybody gets nowadays as standard protocol, and blood products, and definitely still we see, though howsoever we say, but still surgeons and most of the people like to use NSAID in trauma patient. Howsoever we insist it should not be used. So all this thing has received in the previous hospital. So I'll start with Manoj. If this kind of patient comes to you, how will you manage this patient?
I'll start from reverse. So he received Merotargo, so I will de-escalate from day one, because my priorities here is better triage, which was probably not taken care. The fever, tachypnea, hypertension and tachycardia looks to be actually a combination of inflammatory response, hyporesuscitation and ongoing analgesia need. So antibiotics are less priority here. He would have definitely colonized. Probably you have a slide next. So I'll actually give good critical care for the first 12 hours. Send cultures, do ultrasound, do the screen. If there are possible surgical correctable causes, I'll think about it.
Radhavir, you want to add something?
Yes. Whenever we receive the patient, first we assess for he need antibiotic or not. Just this patient is come from other hospital. Otherwise, I think every hospital when a patient coming on the trauma side, immediately people prescribe the antibiotics. So
So why, just my question, why do we need to give antibiotic on first 24 hours of the closed trauma?
Yeah, that's my question. All same question. Why it's needed? But
we'll ask everybody, why do we need it?
Two drug in the every prescription on the ICU patient or even in the hospitalized patient, even the infarct patient, trauma patient, antibiotic and pantoprazole or reviprazole or either acilo. The two drug every time I am thinking, even in the poisoning, every patient will receive two thing everyone is right. That is question. We need to aware the doctors, not the general public. If you go back last year, ISCCM started awareness in the general public regarding the antibiotic. I think we need to aware in the doctors. We need really antibiotic for every patient or should not?
Srikant, any comment on that?
Yeah, I would totally agree with what Dr. Manoj said. Young patient, 24 years, coming from the community, a closed injury, not immunocompromised, immunosuppressed by any means. So no risk for as such that you would first of all start with higher end antibiotics. So it's a community acquired infection. First and foremost, there was no indication for antibiotics, as he said, and the tachycardia could be just a manifestation of poor resuscitation and underlying hypovolemia. Low grade fever can come with any kind of injury as a part of your stress response. Even the counts can be raised at least in the first 24, 48 hours or so. So a knee-jerk reaction which we have towards prescribing antibiotic as a part of your drug cart which you are trying to fill doesn't really make a lot of sense and should be strongly avoided. What we are actually trying to push the patient is we are already shooting off our best bullets in the start and then we are left with nothing much except for the drug resistant bugs.
So what we have consensus in a closed injuries like this, which needs more of observation and pain control, and maybe timely surgical intervention, that is also close. Giving this kind of antibiotic is really not only harmful in general for community, not only costly, but I will be discussing other principles, I will come to that, but it's harmful in general to everybody, to the patient, to the community, and particularly to the pocket as well. So in general, the message we want to give this kind of injury, really you don't need to give any antibiotic.
So going with the slide, every time you give antibiotics, you are not only putting the patient at the amount of extra cost and other things, you are actually exposing the community to a
That's what I said.
drug
That's what
resistant bug.
I will be coming. Ritesh, what is the reason why people, despite thousand times we discuss, we don't need antibiotic in this, we don't need to give antibiotic in poisoning, we don't need antibiotic given a stroke patient, but why do people give antibiotic?
People say, why not? So 99% of people said, fever.
Anyway,
High count,
just
yeah.
one question to audience. How many of you will not give this antibiotic if this kind of polytrauma patient comes to you? How many of you will not give, including everybody? At least few are there. Anybody of you would like to give antibiotic on day one to this patient?
No.
So, okay. So why do
I'll just
people do
come-
that?
yeah. So the thing is that in spite of being aware, what is the intensity of awareness and what is kind of safety and security in the brain? छोड़ना यार दे देते ना बाद में देखेंगे. Now this देख लेंगे episode usually is believed on that fever is considered as sign of antibiotic deficiency. Any fever, any tachypnea or any high WBC count, patient is in sepsis, and for that if this high intensity trauma, even if it is closed, people take this as not only antibiotic deficiency but something I call Marotico syndrome. Cover everything including MRSA का full form भी नहीं पता होगा वो भी देगा antibiotic. But Marotico syndrome give highest of antibiotic, and believe me, there are still people who believe that giving antibiotic, higher antibiotic, so-called higher, there is no word like higher antibiotic, it is broad spectrum. decreases the chances of sepsis and decreases the length of stay in ICU. People really believe that. It is exactly other way around. You are feeding the bacteria which are yet to be grown by giving antibiotic. You are inviting a bigger demon like later on fungus. And third thing, that we need to consider that this is polytrauma patients who are going to stay in ICU for very long period, many times. So you have to go for stage wise. If at all you want to give antibiotic, we should not give antibiotic. We need to dare not to give antibiotic. You are there in front of patient. You can always give antibiotic at 2 a.m., right? So have some plan and then go ahead.
What is the myth? What is the problem of giving antibiotic when it is not required? What problem it causes? There is
Sir,
suggestive slide for
yes, you have very well mentioned in the slides that we all are colonized with some of the bacteria, and those bacteria are good for us. Giving antibiotic will lead to killing of those good bacteria, and it will lead to selection of the resistant bacteria, which can also be the part of the human flora. And ultimately, the resistant bacteria will multiply and they will overgrow the normal flora or the good bacteria, and that can lead to the infection with the resistant bacteria. So this is a very detrimental effect of giving unnecessary antibiotics. And why people are using antibiotic, I wanted to add one line that inertia to think is the main reason people are using so much of antibiotic. Nobody would like to think why I'm giving this antibiotic. So I think this is the main reason people are using so much of antibiotic unnecessarily.
Manoj, would you like to describe pressure selection? Because it's very important, people should know why the concept we are discussing.
So in continuum with what we are talking is, as soon as we expose this body to these antibiotics, so as he's trying to show in this figure, all the bacteria will change the genomics and they will actually overgrow against these antibiotics, and they will form a colony which will definitely is a pathophysiology of pressure selection. So this is the beginning of the problem. And to answer one more in a light way, except stroke and MI, rest of the patients still physician and surgeon domain, and they dominate. So these patients will definitely go to us, and the Khatla-Batla syndrome. If you are admitted under me, antibiotic and fluid is my birthright to prescribe. That is why this has been given to all who are admitted.
So just basically you have to understand that when you are giving somebody any antibiotic, if you give ceftriaxone and quinolones, the incidence and prevalence will be very high, which evidence so. But if you expose to somebody on any antibiotic, the gut flora, because gut flora is a generator of the resistance. This will kill the microbes which are healthy and which improves your immunity, and that will lead to the generation of resistant bug. And those resistant bug multiplies, and once in your phase of down towards your immunity, these bugs who are colonizer become source of infection. And what is the implication of this knowledge? Why do we need to know that this microbiome MDR somebody is generating? How we can inculcate in our practice? What investigation especially you do to our gut flora is infiltrated with the resistant microbes? Do you have some protocol to find that? Anybody can answer. Because this is very important to
Like we can look for the colonizers with the resistant bacteria through either nasal swab cultures or the rectal swab cultures.
So just to tell you that what I would have done to add to Manoj's thing, one more thing, when I get this kind of patient which are exposed to antibiotic, at least nasal and rectal swab is must for all patients to find if my patient is colonized with MDR bugs, and that helps me in selecting the previous antibiotic till I get culture positive report or something like that. This is another thing which we add, because if somebody is colonized coming with fear, suspected sepsis with MDR bug, probably I will escalate, and otherwise I will get down. Crowd also need to understand what is the difference between colonization, infection, and sepsis. So I think you describe colonization. Anybody can talk about infection and then sepsis, because these three things are always intermixed. Particularly infection and sepsis is taken one, which is not, it's a pole apart thing. So please, anybody can.
Yeah, colonization is very clear, that already been mentioned. Infection means it
So
produces.
colonization is just that we all having bacteria which are friendly to our
Yes.
skin, eyes, brain, gut. Particularly gut microbiota is very important. In fact, gut controls our brain by having healthy microbiota. There's a lot of plenty of evidence about that. So this is the thing. So very precisely what is the infection and what is sepsis, this we need to know. Does
See,
anybody understand what is the difference?
yeah, I think better
Most of
to ask.
do you really know that there should be difference between infection and sepsis? You would understand it's two different things or it's one thing? Okay, I think we need to explain it. So please go ahead.
So infection is identifiable source, that you know that is pneumonic patch, there is some urine infection, something or that, giving symptoms, which are same as inflammatory symptoms, but with identifiable source. And if it comes to some organ dysfunction, it turns that it has gone into other more than one side. So it is called sepsis, right? So be very, very clear about that in a colonization versus infection versus sepsis.
Anything you want to add something? Just clinical implication for this?
Suppose this patient unfortunately lands on the ventilator and you send a tracheal swab just as a surveillance method, and it just grows something, but he is not showing any signs of infection in terms of lung organ damage itself, lung itself. He doesn't show any patch, he doesn't show through any fever, so that was just a colonization. But if the same patient starts showing signs of infection of the organ, high oxygen requirement, just need of antipyretics round the clock, purulence of the secretion, that is infection. With the same patient on continuum demonstrates signs of organ dysfunction, ventilator not getting stabilized, means hypoxia worsening, hypotension happening, altered sensorium happening, or coagulopathy happening, this is sepsis. So this is a continuum of a colonization, which probably in the beginning you gave so much antibiotics that the pressure from the gut microbiota actually made this bacteria a ghost, and now they are killing the host. So this is a continuum of colonization, infection, and now sepsis.
So just to make it very clear, the definition of sepsis is uncontrolled immune response and infection is controlled immune response. So if you get pneumonia, which is not showing sign of respiratory failure, you can give antibiotic, keep it at home, patient is stable, is infection. But if same pneumonia is causing respiratory failure or any organ dysfunction, then it becomes sepsis. It's very important to know because treating infection is very easy because you have to give appropriate antibiotic. But when patient go to sepsis, patient needs multi-pronged support, and then cost increases and complication increases, outcome becomes bad. Unfortunate part of this journey is when colonizer become infection and when infection becomes sepsis, it's very difficult to know and recognize. And that's the reason sepsis has got such a high mortality. And some of you want to add?
I add one thing. As in previous lectures, one panelist already tell you fifth mortality cause is heterogenic. So when you give the antibiotic, the colonization become an infection, and infection become a pass in the sepsis. So that is the heterogenic cause, the use of the excessive antibiotic.
So just to give an data that we have many fatal resistant bug, but out of that 6 most important, we don't have our data, but they cause such a huge cost to the check payer, or maybe exchequer, or maybe individual. So here most of the patient pays of their pocket. So anything becoming resistant and cost even increase and you don't know the outcome. So this you have to understand very clearly. And we need to know the infection pattern because it's different in US or European country or maybe country like China or maybe our country. And even inter-individual hospital ICU will have a different kind of flora. So you should be aware about your ICU flora. You should be aware also about the antibiogram of your patient because that helps in deciding the antibiotics. One of the biggest challenge here again is that we are very prompt in giving antibiotics. But when it comes sending to the culture in time, we are less, okay, we don't want to, I really don't know why it happens. that a culture of treating symptomatically is widespread rather than finding the cause and hitting. So this is another one thought process or one perception. You can be successful in 70%, probably that patient do not need real intervention of yours, but in 30% of the patient who really needs your help, if you don't try to find the cause, believe me, you will never be able to treat the patient. I'm not talking any rocket science. It's as simple as everybody know, but we don't walk our talk. We don't practice what has been taught to us, and that's where the problem happens. So just coming to that, community-acquired MDR infection is a big challenge for us. Who are the patients who are at high risk of getting community-acquired multi-drug resistant infection, and where we have to be careful? Anybody can answer. I will not specify because I don't know who wants to answer what. So it's up to you.
So I'll take the lead. CA-MDR is very highly prevalent even in any small town or city. See, you should see why we are suddenly seeing tropical infections on rise because of our sanitization problem. So those who are at risk, number one, are the ones who have a very high frailty index, who are very frail at home, or they have probably an indwelling catheter. They are already on some inhaled therapies like lung disease patient, already who have comorbidities needing them to go to the hospital every now and then, are on immunosuppression. So they are the ones who either are frail or on some medical therapy or on some things which actually increase their chances of colonization, as is very beautiful diagram you have shown, from the livestock or the vegetarian. It is not different from a vegetarian to a non-vegetarian diet. All of us are actually colonized with good and bad bacteria. It is when you are at risk, the ones which I described, you are at a high risk of having a community-acquired multi-drug resistance on arrival, no matter what is the source. It may be UTI, it may be a simple gastroenteritis, it may be simple cough and cold, even simple viral fever. Patients have MDR bacteria as a cause of death, not the virus which made them come to the hospital.
Yeah, having said that, what this thing is actually trying to show is that of the 100% utilization of antibiotics, 75% is used in the livestock, poultry, and food processing. 75%, imagine. 25% is what the antibiotics which receives to the human beings. So 75%. And if you just have a simple Google search, we are more bacteria than human, actually. The number of bacterial cells within the human body is in trillions. And actually, when we say hum, actually hummy hai. We and bacteria together living as in a kind of a symbiotic relationship. Now, the symbiotic relationship is obviously spoiled by our rampant use, both in the community as well as in whatever food and processed food we eat. And as Manoj said, those people who are already frail, who are at risk, who have indwelling catheters, repeated hospitalization, antibiotic exposures at regular intervals, so they get colonized. And then in case their immune response goes down for whatever reason, may it be a natural aging process as you have mentioned here, or because of any concurrent infection, the balance between a colonization to the infective process takes over much more rapidly. And that causes extreme proliferation of this, and further worsened by our own activities, which is giving high-end antibiotics right at the start.
I'll just add to that, yes, as Dr. Srikanth said, there is use in some other field like he already mentioned. What is there in our hand? Actually, the commonest use I would say is misuse and overuse of antibiotics by us in terms of inappropriate dosage also, in terms of inappropriate combinations also, in terms of inappropriate very long duration, including surgical prophylaxis for 10 days, even at home. After 5 days, patient is walking and talking, all of us, we give antibiotic for another 5 days, 10 days, 20 days. So this inappropriate misuse and overuse of antibiotics, when that patient is exposed to some real infection, those antibiotics are gone. So those bugs which get colonized, they turn into infective organisms in such a way that the routine, very narrow spectrum antibiotics, which are excellent to use, are not effective. So I would say what is there in our hand is to curtail this thing: inappropriate use, underdose, inappropriate duration, inappropriate combination. Very few patients require combination of drugs. And how many of, let us have audit of ourselves, how many of us literally use single antibiotic in most of the patients? I'm not talking about only sick patients, I'm talking about general patients also. So we need to audit ourselves, that do we need this antibiotic? And believe me, if you audit really well, then the same two antibiotics have the same spectrum of coverage of bacteria. So these audits did literally, I would say, what is there in our hand, we try to focus on that rather than only, yes, those regulations are necessary. That is 75% of use is in poultry and animals and so on and so forth.
Just to conclude the previous slide discussion, we all of us get exposed to antibiotic from community, but preferably from the livestock's use, particularly their urine and that manure get mixed to the environment thing, and then it goes to the agriculture field, and from there you are getting exposed. So this is something we have to be concerned that if you are not taking care of our environment, and particularly the area where antibiotic is exposed excessively, knowingly, unknowingly, you are getting whole community is getting exposed to the antibiotic, which we don't know. And then we have not a commensal, which is like colonizer, we have a resistant bug as a colonizer. And when our immunity dips down, as I have said in next slide, this colonizer becomes source of sepsis for us, and that's the problem. So most of the time, the infection which we are getting, bad infection we are getting from our own body, not from somewhere outside. And this unknowingly we have been exposed, sometime knowingly, unknowingly, for antibiotic, which probably we don't know. So this is one thing which we have to know, and that's the reason nowadays in West, all over the world, talk of the green environment, green issue, everything green. And this is the one of the implication of green thing is that everything is being polluted, and now we have commercialized, we have become industrialized, now we need to go back what it was there. So we need to get exposure. Can anybody take the question of immunosenescence? You want to like explain? Immunosenescence, Madam? Or
Basically, immunosenescence means decrease in the immunity with the age, with the advancement of the age. There is a decrease in the immunity, it is called immunosenescence. There are many diseases which are more severe in the elderly age or more in the very young age. This is because of the immunosenescence. We all know the shingles. This is just an example. The chicken pox virus which we acquire in the childhood, which becomes active with the advancement of the age, and we get the shingles. This is just the example of immunosenescence.
okay.
So
Just quickly give example, when you are born, your immunity is low, and then you exposed to different virus, bacterial, and then you have a memory cell form. But as you grow old, and when particularly you become 50 and 60 plus, and if you have a diabetes or any other immunosuppressive condition, maybe you are unimmunosuppressant, your memory cells start getting apoptotic or they dies down, and that's why immunity is low. Implication of this thing is that when you are practicing as a physician, adult vaccination program, particularly if somebody is 55 plus, maximum 60, we prefer now 50. And if you are a patient having diabetes, COPD, hypertension, LB problem, liver and kidney disease, at least you should start adult vaccination program promptly or proactively start doing that. So that will improve the herd immunity in general, and that will help us in preventing the seriousness of disease. So even somebody gets swine flu or pneumonia, it will be not that severe who has not received the vaccine. And that will help us in saving more patients. Antibiotic stewardship. Just I will say something and then I'll ask question. So, antibiotic stewardship is not something which I'm talking about new. Everybody knows. And everybody also knows that it failed badly. It failed badly across the world. Even in the places who has launched antibiotic stewardship program, they could not implement even in 40% of the hospital. I'm talking about this data from Europe and USA. I'm not asking about what antibiotic stewardship everybody knows about. I want to know why it failed and how we can have a Indian version of our version of antibiotic stewardship program based on this principle to have better implementation. Anybody can take this question. Why antibiotic stewardship failed?
Again,
And if nobody wants to take question, I can answer.
yeah, again, the problem is there is no regulatory check, number one. Number two, there is too much of self-medication. Number three, availability of antibiotics over the counter. Now, what we call is azithromycin, probably the domestic use, everyone, keeps as a travel pack also azithromycin, that people use so much. So these two, three things are the core, definitely, over and above what I already said, that we do not audit ourselves. One need to be aware that if I need antibiotic, I need to preserve. This is the inner voice, I would say. Over and above, सब inner voice से नहीं होता है, कभी डंडे की भाषा भी चलती है. So we need to have some regularization from the government, having justification of utilization of antibiotic not only OTC but in hospital use also. So these are the common points that I would say that the reason for failed antibiotic stewardship.
Just a question. How many of you know the real meaning of stewardship? Anybody? So stewardship means I trust you and I give my responsibility to take care of me. So that's why air hostess stewardship is there, antibiotic stewardship, just to make you understand. The antibiotic stewardship, one of the biggest problem has been, there have been so many human intervention and there has been poor coordination among each other. And everything needed individualized training than coordination, which is an impossible task to get so many heads to train appropriately and then coordinate. And that is one of the reason it has failed. Out of all component which has demonstrated the best result, what he was saying, Dr. Ritesh was saying, that audit and feedback, this is something which is the best in our thing, that is also 40-50%. Other component has failed badly. But somewhere down the line, if we want to win over the antibiotic prevention of resistance, we need to have regulatory. We have to regulation in hospital, at pharmacy, at state, at central level. But individual responsibility is very important, knowing that we are doing, I don't want to that what somebody else does. Howsoever sick somebody comes to me as an adult person who is immunocompromised, he comes with upper respiratory infection. Unless I find somebody has chance of infection, I will not give more than azithromycin, irrespective of whatever somebody says. Yeah, I investigate more. I will try to find he has not got H1N1, he has not got any atypical infection, or he has not colonized with strepto and MRSA. That's a different story. Nobody is going to die with fever or infection in one day. Yeah, so somebody can die in sepsis within few hours. And that's the reason you need to recognize that patient is having fever and infection. Unfortunate part is that we say infection is sepsis and sepsis we say infection. That interchange, and that's create confusion. Nobody is going to die with a controlled immune response within few hours. You have a time, all the time, till evening to find the bug, to do the stain. So that's one of the things which we want to give message.
Shall I add something?
Yeah, please, please.
To me, antibiotic stewardship has not failed because I take care of my patient and I will always take care of the duration of antibiotic. It's if you all agree today and you go and see, if you are giving antibiotics beyond 7 days, that means you have failed as a doctor. So I disagree that it has failed. It has failed because of the pressure of industry. Corporate hospitals do not want to budge into that because they want sales and sales and sales going on. And that is how we are here sitting with Abhishek.
So this is one of the other reason why antibiotic failed. I tell you, this is another reason why antibiotic failed. That individual excellence is not important when it's a teamwork.
Yes.
It's a responsibility of so many people. That's why I said, there are few components fail. I did not say it's 100% fail. In better setup, it is 50% successful, but I'm talking about where people. But as generally it has failed or not served the purpose, this is one of the reasons.
So last week we presented a case journal article which is published in Lancet. It's an Asian paper of duration of antibiotics in patients with multi-drug resistance antibiotic. They have proved that giving antibiotics in MDR bugs for 3 to 5 days is as equal to giving beyond 7 days. So this is a very good paper, Lancet, and again, unfortunately, India is not a part of that trial, but it is a very good paper. I'll share to Abhishek. So if people are doing a trial from Asia of 3 to 5 days of duration of antibiotic in the same subset, so where are we? Are we a leader or are we just having a tag? So if you're a leader of a patient, real steward of a patient, you should take care of the duration. The day you start, you should be honest enough to write 1/5 and then revisit on the 5th day. That is where our problem is. So you have to be a successful steward the day you start antibiotics in your
So very
ICU.
quickly, this is some basic plan from WHO, and again, here we don't need to be expert, we don't need to be doctor. All are the education, training, awareness, and feedback, and control measures. You don't need to be really expert doctor to follow the stewardship program. They are basic thing. But the self-control and regulatory, and particularly the education and training is very important. That's what we are doing. But this should aware. If do not increase awareness, it is stay here, you listen here and forget, all this discussion is of no use. But if you implement this thing in your knowledge, okay, at least I follow this thing, at least one person doing, then 10 will follow. If nobody is doing, nobody follow. So at least that's where we have to do the leadership role and follow these simple steps. And as I said, building successful program is most important thing is that a team building with equal responsibility and spreading the knowledge. If somebody say ki I can do individually, it will never succeed. And that's why it has never succeeded. I have to just quickly 2-minute rest. I want to just, so what are the options, which were as another lesson we want. What are the options of current available antibiotic resistance? There are some 8 common resistance which we all faces every day and out. So what are the common available combination to manage this quickly, one by one, somebody can take. And then I want you to comment also some of the new, which is particularly indigenous, like ceftriaxone, sulbactam, EDTA, meropenem, sulbactam, EDTA, if you have any experience, or newer aminoglycoside, like rapamycin or plazomycin coming. What will be the role in managing this MDR? Quickly, and then we go to the last slide, because we are just having, how do I have, I think I was given 5 minutes, I have 2 minutes, shall I stop 2 minutes? I have 5 more minutes. Okay, fine.
So
Quickly.
I will not be discussing in detail. I will be just giving my choice of antibiotics, 1 or 2 for all these bacteria.
You take one by one, everybody you give opportunity, you just take. We have 8 options, 2 you take, rest of the thing they can take.
Okay. Third generation cephalosporin resistant E. coli, I would go for the carbapenems. Fluoroquinolone resistant E. coli, again, if it is sensitive to third generation cephalosporin, then I would prefer third generation cephalosporin. Penicillin resistant streptopneumoniae, third generation cephalosporin are the drug of choice. MRSA, here the vancomycin or the linezolid, depending on the site of infection. Carbapenem resistant Klebsiella pneumoniae, now we have very good data of ceftazidime, avibactam and estonam combination.
Everybody is on that nowadays.
No, everybody is aware of that, so I don't need to go into that. Third generation cephalosporin resistant Klebsiella pneumoniae, again carbapenems are the good option. Carbapenem resistant Pseudomonas aeruginosa. Here there is a very difficult choice. I in my practice we still use the colistin or the polymyxin B for Pseudomonas aeruginosa. Vancomycin resistance Enterococcus faecalis and Physium. Here we have option like daptomycin or linezolid for the vancomycin resistance Enterococcus. And I think.
Anything you want to add further?
Yeah, I would say I would go for molecular testing whenever it is available, so as to save the colistin. What in our last drama we did in Karamsad also is a polymyxindra bahubali. Because right now only bahubali which is available to us is polymyxin group, and our bahubali is there also. He acted as a bahubali. So if we want to save, go for molecular test to know that the resistant pattern, so as to save patient from exposure to polymyxin group of antibiotic. You can go for whether it is Oxa 48 versus NDM versus combo. Plus, it's on not only that, but patient selection, that whether patient really needs that, with colonizing versus infection. If it's showing signs of sepsis and all, then you need to go, if it's Oxa 48 positive, then ceftazidime, avibactam plus estonam combination. If NDM, then you can go for polymyxin group.
Just to
Yeah.
quickly, because we have another slide, just to quickly, whenever you grow bug, ask for MIC and select the best combination of drug which is sensitive, depending upon the better penetration. Don't select a drug which doesn't, like if you are selecting tigecycline for brain, or you are selecting tigecycline for lungs, you have better option to treat that. TG is very good in gut. Just I give example. So select, try to find the MIC and select a drug which penetrate the site better, you will have better result. That's what the message I want to. Very quickly, you have other slides to discuss, just because this is very important for us as intensive. So surviving sepsis bundle has come out with treating sepsis and this thing. What they lack, they never discuss what will you do when you have MDR sepsis. So very specific, because we are lack of time and we have taken 5-minute grace. What would you like to add in surviving sepsis campaign bundle, especially looking to MDR sepsis? Because in tertiary cancer center where we work, most of the patients we get, like if I get 10 referral, 10 out of 10 are MDR sepsis, not like, it's very clear. So what additional thing would you like to add in your bundles of treatment in managing MDR sepsis when patient comes to you first time?
So remember, the MDR sepsis is always in a existingly ill patient. It's not a new patient. So we need to initially, in the first 3 hours, actually target the source first, add on to that in new onset sepsis. Second is the second statement, what you said, give broad spectrum antibiotics. I will add on to that combination plus as per the source, as per the source. So sicker the patient, you expect MDR. But if you are expecting MDR in non-sick patient, it is just because he is lying in your ICU for 2 weeks, he'll grow those bags. So that is what I want to add there.
Shrikant, anything specific?
I think that's what he has, and hopefully in the future we will have more of a rapid diagnostic techniques which will actually give you the mechanism of resistance, and you can select accordingly. I mean, that is coming. It's coming up. It should come up in the future.
What we can do right now, because that's where I wanted to come with that point of care diagnostics. So that's what I wanted to, like right now when a patient comes, like previous patient they comes, so not only colonizer, we go for rapid diagnostic test. And like AI, the point of care test is future, and not far away, maybe 2 or 3 years down the line, most of the tests which you send in lab will be available in your ICU, and you have to just put few drops of blood. You will know what bug is, you will know what kind of severity organ dysfunction patient has. Most of the things will be point of care test, and that's where our decision making is going to be fast. So probably in our 3 hours bundle, I would like to add point of care diagnostic to find the bug quickly, because in 6 hours, this RT-PCR based test tell us the probable bug which I am growing, and that helps me in precising my antibiotics and probably the location. So I would like to localize the things, and I would like to find what bugs I'm growing to take my decision. That's an additional thing which we want to add the this 3 hours or 6 hours bundle. And how this test works and going to work is basically, right now we are working based on the RT-PCR, but the things biosensor, this is where a lot of work going on and a lot of with success. And as I said, maybe 1 year, 2 years down the line, you will think a lot of things coming as a point of care to help you in taking better decision in sepsis. So how AI will help? A big session, just previous one, in 2 things, in taking our decision and implementing antibiotic stewardship in our day-to-day practice. So anybody wants to take answer, or shall I talk on this? Okay. So what happened that basically, in a simple word, if you talk about AI everybody talking about, AI is something where you give millions of data. This I give a very simple example. All of us know about the respiratory rate. Most ignore and most specific sign in picking up the severity early. And over and above, not only, can you stop this please? Okay. So most specific above rate, respiratory rate is the respiratory pattern. Unfortunately, we as a human, respiratory pattern, if you talk about the youngsters, they will not understand. To get our eyes trained to recognize respiratory pattern and find out what complication patient have is really need, but needs a lot of expertise and years of experience. It's not something you can learn in a day. But the same module, we are training our machine in just few months to predict better than even expert. The same way when you enter any particular data and pattern in a machine and memorize it, That's a million data. It becomes more sensitive and specific, which as a human being, we do not have the capacity to remember and implement. Same problem with antibiotic here is that decision taking. Look, we did not, so far, our prognosis and outcome in sepsis is bad because we could not diagnose sepsis early. If you cannot diagnose early, you cannot treat early. And that's where prognosis is bad. AI is going to help us in two ways. In finding, because all these biosensor and point of care test-based technology will help us in detecting. And when we are going to calculate this thing, will implement early. In fact, time is coming where we will be able to predict that this group of patients precisely will go in sepsis from infection, and this group of patients will not go in sepsis. And that will help us in titrating our treatment where this patient should go. Okay? Same for antimicrobial resistant or antibiotic stewardship program. It will be very easy for me to multiply. If I do something, I do one training program, I just train my machine. It will be very easy for me to multiply it and to train thousands of people easily, which I cannot do things. So a lot of places, artificial intelligence is going to play a big role in sepsis management, and that's where we see future as management. And that's where it will save our, this was the concept of time game coming, that I can diagnose early, I can treat early, because sepsis is a syndrome. Sepsis is not one organ disease. Infection is a one organ disease, but when we talk about sepsis, it's a syndrome, and that's why we face all difficulty. That's why antibiotic has a very little role. There are thousands of things which improves. It has a role, but shows thousands of things we have to do in sepsis to manage. So time gain is one concept which AI is going to help us in early predicting the patient who is going to in sepsis from infection, and that's where we expect our outcome will change. So precise MDR sepsis management is something which is the future, and thank you for all your attention.
Yes, I would like to take this opportunity. We did last year one drama on superbugs versus super drugs. Please go through. Samir and team can just circulate the link in a funniest way possible. We have just tried to convey about the basics of antibiotics, where to use, where not to use. Thank you.
तो हैप्पीनेस का एक सिंपल फार्मूला है कि जो चीज़ हमारे कंट्रोल में नहीं है उसके बारे में मत सोचिए. डू योर बिट्स, एंड इफ यू आर डूइंग योर बिट्स यू शुड फील हैप्पी, बिकॉज इफ यू विल ट्राई टू कंट्रोल द वर्ल्ड यू विल डाई, और वर्ल्ड विल ईट यू. भाई सुनिए, लंदन के प्रॉब्लम डिफरेंट लेवल पे है. बिना प्रॉब्लम की कोई जिंदगी नहीं है. ऐसी कोई जिंदगी नहीं है कि किसी भी स्टेज में किसी को प्रॉब्लम नहीं है. तो डोंट से कि देयर इज नो प्रॉब्लम. और कोविड ने सबका बता दिया कि किसकी कितनी प्रॉब्लम है. तो डोंट वरी दैट वेयर एवर यू आर. बस आई जस्ट बिलीव इन दिस थिंग, ओनली सिंपल कर्मा. यू डू योर बिट ऑनेस्टली. Don't worry about what others are doing. If you are honest, if you are getting good sleep in night, is good. If you are, what we are discussing, if you trust in the principle, just follow that, is more than enough.
But try to spread the message.
Sir,
Try.
Sir, again, I tell you, now the culture or microbiology is very standardized. There is a agency, or there is like, you have NABH, you have their own thing, which standardize that this you get. And as I said, that most of the time, if any microbiology lab is giving you MIC, that means it's following. So if you talk about standardization, if you are getting MIC report in a culture, then it should be fair enough. Depends upon when you send culture. I tell you, I don't know, any physician please don't feel offended, but how many times it happens that upper respiratory patient comes to you and you ask for nasal swab for virus and just what colonizer or bacteria is? Nobody. You must be giving any antibiotic. Maybe you are giving azithromycin, no antibiotic. I just give you data. If you have 100 patients, this if you don't see it, 5 or 8 of these patients may be having bad H1N1 infection or flu infection of seasonal, and some of them may having atypical infection. Over a period of 72 hours, the antibiotic which you are giving is not helping, it's probably either doing bad or maybe helping in bringing down his immunity because of the disease. And after 3 to 5 days, this patient converts into pneumonia. So the time patient comes to you, and if you investigate, and if you find that he was colonized with this, or he has this viral infection, probably you would have treated or not treated, at least you know that he is growing and given appropriate antibiotic. So by the time he goes in pneumonia and respiratory failure, things are very late. Particularly it has happened in flu. Once it gone to lung, has gone to ARDS, you give antiviral, it doesn't give, it doesn't. It works only until as long as it stays in your upper respiratory tract. Once it's gone to alveoli, it doesn't work. So these are simple things we are saying. So standardization means you know what kind of lab it is. It is approved by given agencies up there, and if they give report in MIC, it should be fair enough.
We are doing a one-day workshop on how to intubate, one-day hands-on workshop for physicians working in intensive care in August in Ahmedabad.
Yeah, the problem is many times,
You
you know,
mentioned now when a patient come on clinician advise in nasal swab, the practical problem is done. Some are the fact or some are the practical problem for the clinician also. As soon as patient coming, अगर आपने इतना test advise कर दिया ना, he will never
No,
return to.
it is a mindset. No,
test
I
बहुत
tell you,
लिखते हैं.
it is the mindset.
I don't
If you
agree
can,
with that.
if
No,
you can,
I don't agree with that.
if you can prescribe antibiotic, and if you make a rule, without culture you will not get antibiotic. If you think antibiotic is needed, if you are just giving empirically for viral infection, you are doing harm. So this is the mindset. It's not like that. Look, same patient, I tell you, same patient when he gets sick, he ends up spending lakhs and lakhs of rupees. And the moment you tell, because what happened, we are busy so much in seeing hundreds of patients, that this important thing is nobody trying to say, or trying to explain. Some of the patient may argue, कि sir, दवा तो लिख दीजिए, ऐसे ही we don't, why you want investigation? At least आप basic CBC, SR, CRP तो कर लो यार. आप अगर उसमें अगर आपको कोई बैक्टीरियल इन्फेक्शन मिलता है शाम तो तब एंटीबायोटिक दो, अगर लगता है चलिए आप डोंट वांट टू सेंड कल्चर, CBCSR CRP की इतनी कॉस्ट नहीं होती. आप बिना कुछ इन्वेस्टिगेशन के जो एंटीबायोटिक लिखने का एक ट्रेंड है ना, that is 70-80%, not एक छोटा नंबर है. Most of the people, as long as you don't change mindset, as long as you don't change thought process, it will not happen.
I think I agree. See, the thing is that if anyone goes to pediatrician with that child, and if pediatrician prescribes antibiotic, अरे यार देखो ना सर, without antibiotic अगर होता है तो symptomatic, and the same person wants antibiotic, if you don't prescribe, then say कि यार क्या है symptomatic तो मैं भी ले सकता था. We need to, it is our duty to change that mindset कि भाई ये है, अगर होगा तो we will prescribe antibiotic. Don't give, I don't give unnecessary.
Yeah, so 35 years of experience as a clinician, I tell you that the problem is that we are not explaining the patient. That's the first thing. I'll give you one simile because I practice diabetes a lot. The Ribelsus, oral semaglutide came. Now, if you are not giving the option to the patient, thinking that they would say that I'm writing a very expensive medicine, is your presupposition. I think the problem is that our communication really needs the biggest training. Then nobody is going to tell you that you are expensive or you are not expensive, right? So I think the problem lies with us. It's a communication with the patient, whether it's ICU or a routine practice.
I 100% agree with you, sir. I fully agree with you. This is the fact. I just said that, I tell you, just example. There's a patient I was seeing for multiple problem in OPD, was seen by rheumatologist, patient has sarcoidosis, patient was not getting better, and started developing cardiomyopathy and all these things. So I said, like, you ask your rheumatologist, why he is not giving adalimumab, you are an ideal candidate for it. And then he went. So first question was, rheumatologist was, it's very expensive, can you take this medicine? The patient said, sir, this thing we are suffering, at least you should give option. But you are so busy that you are not even told. The physician is telling us that you have to take, and then you are saying it's expensive. So this is not a problem. It's a problem of, in general, that our communication with, we have become probably so busy in practice that we don't tell that this is something which is important. As long as you think in your mind that this is important,
I will not do this thing without this. It will not change. Problem is that काम चल जाता है, कोई पूछता नहीं तो आप चला लेते हैं. Simple सी बात है.
Rajesh.
I think time is up. The organizers are looking like, So let's finish up. Thank you very much.
So we would like to invite our Ahmedabad team, ISU Ahmedabad team. They are going to have a great 10th Gujarat Criticon in the September. Please welcome Dr. Mehul Solanki, Dr. Manoj Singh sir, Amit.
Good afternoon, all of you. I'm Dr. Mehul Solanki, is our patron Dr. Manoj Singh sir, Dr. Amit Prajapati sir. As behalf of Ahmedabad ISCCM team, we heartily invite all of you in our state level conference, that is Gujarat Criticon. This is 10th chapter. Means consecutively, except 1 year of Corona, we are continuously this fallacy of Gujarat Criticon Academic Feast. And I heartily invite all of you. On 22nd of November, it is workshop. We conduct a routine workshop like mechanical ventilator, hemodynamics, USG, what yesterday done. If someone is left and want to attend again, they can attend in 22nd of November. 23 and 24th of November, we conduct the scientific programs conference, huge conference, and that is we are conducting at Club 07, Sela, Ahmedabad, SG Road. So heartily all of invited, whosoever want to register, special rate has been already given, and we are registered very special rate. They either scan the QR code or there's a QR code outside on the standee, they can directly scan from them. Heartily invite all of you.
So the attraction is we are doing the workshops in most of the medical colleges in Ahmedabad, and for students and those who are doing training in intensive care, abstract submission is also open, and we like how we got in this conference a very good response. We are looking at more than 100 abstracts from each from different parts of Gujarat. So we are looking forward to welcome you all. And any comments, Milesh? No, thank you. Rajesh?
No.
And those who are not members of ISCCM, we encourage you to become members, because it's a very robust body, very scientific body, with a lot of players from the central, Ranveer, Ghanshyam, I think Sachin, Srikanth, all of them here. They look forward to Gujarat as a key player in academics in this part of the country. Thank you.